Perfect. All right.
Thank
And
you.
I'm actually going to do a couple of strange things, all kinds of strange things. Number one, I'm actually at the American College of Cardiology meeting, and uh, I'm pretending to have 5 to 7 p.m. open. It's not really true, but I'm going to do my best. Probably need to get out and let everybody go about 6:45. The other one is that because of all of the things that are going on in this country, I need to make sure that when we talk about, you'll notice the title difference. We talk about making progress. What I'm going to convince you of is that one of the major areas that we need to make progress in cardiovascular medicine is health equity. Lastly, we're starting with a quiz. And so I know that they won't put all I see 150 people, and they're not going to put you all off of mute, but you can get in the chat. Okay. And so I've got my chat box open, and we're just going to ask just a couple simple questions and see how just to make sure everyone is engaged in this. All right. Are we ready? Okay. So question number one, what is this? Let's see. Not seeing anything typed so far. Are you? Smallpox. Very good. Thank you. Thank you, Priscilla. That is indeed smallpox. And why is this reformed cardiologist department chair talking about one of the prettiest viruses you'll ever see? Not. It's because I really want to focus on the healthcare disparities that we have. They've been going on for a long time. And there's all kinds of them. There's Native Americans, there's where it's a lot of social determinants of health. There's our South Asian population who economically do very well, but cardiovascularly do very poorly. In this case, we're talking about very much the black-white disparities that people are usually talking about, but don't realize that they go deep into our history as a country or as a hemisphere. So this one is talking about the number of people who, in Nakayama's article earlier last year, really talking about the number of people who were dying because smallpox was spread person to person with local contact. And so it turns out that you could look at Ben Franklin's publication. Ben Franklin got into this because he was an 18th century anti-vaxxer. And as I'll show you in a moment, there was an inoculation that he talks about here. And that inoculation, he was refusing to do it, and his son died at age 4. And so then he flipped completely and started publishing on the topic. And these may not look like a lot of blacks were dying, except that these were just enslaved. The number of slaves in the North in Boston was actually fairly small. So this was a huge disparity in terms of black-white mortality. So what was the solution? As Ben Franklin, really published and tried to get other people not to make the mistake that he did. It was actually brought from West Africa by a 6-year-old slave who became, who was in Boston as an adult. But he remembered being 6-year-old in West Africa and seeing smallpox outbreaks and having the older people take little inoculations out of the pustules of one person, stick them in the other, and that person usually did not die and ended up being protected. And so that whole idea went back quite a ways. And once that became the standard of care in the 18th century, what you saw was it took some gradual adoption, no question about it. But what you saw is the number of deaths going down and the black-white differences disappearing. Why? Because the disease disappeared. Okay. New question. So who can tell me where this is? Oops. Sorry. Hopefully you didn't see that. Anyone? Panama Canal. Very good. Thank you. Oh, we got a lot of people. Thank you. All right. And so, so why is this guy talking about water? Well, this is an important piece of 19th century history. You can see that if you're a business person and you were in China or Europe and you wanted to get to the other hemisphere, the easiest way to do it would be if you could cross that land in Panama, because it was the narrowest area, and you didn't have to go around the Cape, excuse me, the Cape of South America. And so this was a big economic boon to business. And there was a lot of effort put mostly by the French to try and get this done. And they hired in the 1880s, 1890s, they hired a bunch of workers who were coming from everywhere to make a decent living for their families. And do you notice anything about the workers? You don't have to answer. It'll be fairly obvious. But if you just look at the workers, you can see that they're African origin, Black. And what was the issue? These were ex-slaves and people who had been freed from slavery, people who were descendants. They were poor, they were Caribbean. And the idea that they could have, make a decent living and send back to their families and support their families because the French were doing this huge business of digging this canal was really great until it wasn't. So does anybody know what happened here in Panama that made the French give up in 1895? Close, Marty. Very close. That's it, Stephen. Yellow fever. So this is the culprit. Okay, maybe this is a good-looking virus, but it's really a major issue. So the Americans got into it. Why? Because of the Spanish-American War. And the Spanish-American War, as Stephen and Marty said, those were the two diseases, malaria and yellow fever, both mosquito-borne, that killed more people than the Spanish army and the American army killed each other. It was really less combat and more of a war of attrition and disease. And so the United States was really determined to figure this out. And U.S., I'm sure everyone recognizes the name Walter Reed because of the hospital named after him, but it was named after him because of the fabulous work that he and his team did to try and figure out how to stop mosquito-borne illnesses. And basically, it was to stop them from breeding. They need water to breed. And all you had to do is every place where you saw standing water, get rid of it, drain it. A little hard to do in a Panama Canal, right? Because you're digging to try to make the water happen. But putting oil on top of it, that actually worked. And so once they solved this problem, the United States went back to Panama and actually finished digging the canal. People were not dying. And they did a marvelous job of making commerce happen between the East and the West. And they paid Panama $100,000 a year. And that contract never changed from like 1905 all the way till 1976 when Jimmy Carter gave it back to them. So anyway, good piece of history. How did you get rid of that huge black-white disparity? Get rid of the disease. So this one I don't need, now we're up to the 20th century. I don't really need to, give much of an introduction about what happened with polio in this nation. Several of us, lived through this, and we all got vaccinated. But what people may not have realized is this was one of the more modern racial disparities. Again, this is a disease of close contact, fecal oral, and it was amazingly more prevalent in the Black community. and including the south side of Chicago where I grew up, and I had friends who had polio, and everybody was, afraid to stay, to be around them, thinking that they were going to catch it, which of course was long gone by then. But the real issue is that by 1964, there were three different uh, vaccines. And so this is by the way, a very special picture. There aren't too many of them showing a TB, I'm sorry, a polio recovery place for Blacks, because they were set up all over, mostly because President Roosevelt had it, but it was a whites only kind of thing. And so how do you get rid of the racial disparities and structural racism that results in more death and disability? The vaccines. And so those three vaccines came out. They competed with each other pretty well. And bottom line was that we ended up with a very effective way of removing a disease that was a blight on everyone, but a huge black-white disparity. Okay, so anyway, that is my introduction to the whole idea. Hopefully, if you've heard any healthcare disparity talks, you've seen this one. But you may not have seen the idea on the right, which is, sure, equality is something to aspire to, but it doesn't help everyone if the needs are different. Equity is where you give people what they need to have success. But what I'm saying through those three examples I just gave you is, why not just remove the fence? And in this case, I'm going to spend the rest of the time talking about cardiovascular disease, because we have an opportunity with each and every one of you to spread the word, to share the data. I know when I'm speaking at Real Truth in Healthcare, that I'm mostly speaking to the choir about plant-based nutrition and prevention, but having the choir have all of the notes of the song exactly right is something that I value very much, so that you can go back. If you're a physician, you can change your practice. If you are a patient who has a physician, you can talk to that physician and get them to understand the importance of prevention rather than just continuing therapies. Okay, and so the facts are overwhelming. Whenever we talk about cardiovascular disease, we do have to mention the healthcare disparities, because it costs us all. The fact that over half of the African American population has some form of cardiovascular disease, but more than that, it's a massive burden in terms of both the finances and the number of people. And it's not just death, it's death and disability. And so people say, oh, well, a stroke, dialysis will cost you, and I'll talk about that in a bit. Dialysis will cost the government, taxpayers, about $100,000 a year. A stroke costs about $40,000. And so we all end up paying. And so it's in all of our, as taxpayers, as citizens, as people in the world, it's really important for us to try and get some semblance of prevention here. Okay, if I click back on. I'm at the American College of Cardiology. If you look up the news from it, you will see a fantastic number of new drugs. And this messenger RNA stuff that we started with COVID has got more applications. There's incredible amounts of small interfering RNAs, molecules that'll change your triglycerides and your LDL and your HDL and your blood pressure. And it sounds really good. But really what we're doing is developing incredibly sophisticated and therefore expensive MOPS. And what I'm hoping that the handful of us who are talking about prevention here will get across is that at some point we have to do more focus on turning off the faucet. Why? Talk about dietary risk, because it's the number one cause of poor health in this country and around the world. We have way too much obesity, fatty liver disease, and diabetes, and we pay for it. This middle bullet here is something that everyone should make sure that their physician knows and their family knows, that 80% of our healthcare dollars, which are toxic levels of expenditures, are actually spent on preventable chronic diseases. If everybody did a whole food plant-based diet and exercised every day, we wouldn't have these issues. It's now up over $1 trillion per year for these expenditures. And it's at some point, we have to recognize that the pharmaceutical industry and the device industry are not designed to bail us out. They're designed to make money for their shareholders, and nothing wrong with that. But it really is something that we should be handling on ourselves. If not, we will continue this trend. This trend seems to be getting worse. I'm going to talk about life expectancy more than a bit, but this data is overwhelming. It's a very saddening slide to look at, saying that we are spending massive amount of money per capita on healthcare. And what are we getting for it? Way less than other developed countries. And so last October, there was a focus in the Washington Post specifically about the decreasing life expectancy in the United States. While it's true that we are having an increase in our aging population, the strange part of that is that it's our older people who are getting older, and our middle-aged people are dying sooner. So that is dragging down the average life expectancy. If you look at it geographically, you'll see some really tough areas, particularly where I moved from Chicago to Kentucky. We have a massive amount of premature death. The death gap between rich and poor is increasing. So again, it's not just racial disparity that we're talking about, it's economic, and that's very true where I'm working now. And it looks like that gap has grown over the years and it just continues to escalate. But both the death rate in the wealthiest areas are upticking as well. And so we have to do something. And that something is prevention. And I'm sure you're hearing a lot about the 6 pillars of lifestyle medicine. And if we could get people off of substances and get them to exercise and do a whole food plant-based diet and control all their numbers, which we'll talk about in a bit, we would have a much better time of getting people through to live out their full life expectancy and continue to pay taxes while they're working, because that's another major crisis, is that if you squeeze the middle when the older people deserve the Medicare because they paid into it, but everything we do is so expensive. It's a tough mathematical formula if the middle ages have premature death and remove themselves from the tax base. So anyway, any way you look at it, you can make a great case for preventive medicine and changing lifestyles. So what happens, Jim Januzzi's group from Harvard, what happens if you don't do anything? If we keep going the way we're going? Nice central illustration about what it would be like, 2025 to 2060, but I'm going to just summarize it for you. All of the major risk factors for heart disease, diabetes, high blood pressure, high cholesterol, obesity, are going to increase. And the interesting part is that it will result, predictably, in more heart attacks, more heart failure, more strokes. But it's actually based on the trends that we're seeing now, it's going to decrease in the white population and increase in racial minorities. So we do have to address our healthcare disparities, or we're all going to pay that price. These were these graphs showing the subtle or not so subtle increases in disease, risk factors, and then the disease themselves, particularly in the non-white population. But all of them, white and non-white, would improve if we could get massive uptake of a whole food plant-based diet and an exercise program with substance avoidance. So the time is now. These future increases are projected. They're not actually going to happen, because I'm trusting that everyone in the sound of my voice is going to take up the mantle and work hard to try to make sure that this doesn't happen. We need to make sure that our healthcare system, our families, our states, our federal government are all behind the kinds of things that are going to make us healthier.